Welcome, ladies and gentlemen. This is a session on medications that we use in people with type 2 diabetes. Over the next 15 minutes or so, we will talk about different medications, the older medicines as well as the newer ones. So in people with type 2 diabetes, the medication that has been used for the longest duration is probably metformin. UKPDS study, which was the United Kingdom prospective diabetes study published in 1997, showed that in people with type 2 diabetes, particularly those who were overweight, had considerable benefit when they were on metformin. The mechanism of action is not quite clear. As lactic acid doses is a side effect of metformin, particularly in renal impairment. It is thought that metformin might interfere with the aerobic metabolism and possibly the Cori lactic acid cycle. Cori cycle, as you might be aware, recycles lactic acid through the liver to form glucose again, and this is the pathway that's used particularly during anaerobic metabolism for rapid energy distribution to actively working muscles. We expect that people on metformin have reduced insulin resistance, which means that they can manage with smaller amounts of insulin. The main side effect is gastrointestinal, and they can get an upset stomach and increased gastric acidity, particularly in the first 2 weeks after they start. We need to use this in caution in conditions where there's dehydration or conditions that can cause lactic acidosis, particularly cardiac failure. The Royal College recommends that we should not use it in renal impairment, particularly once the the estimated glomerular filtration rate falls below 30 ml per minute. The most common drugs that were used in the past and second line on the NICE criteria are the sulfonylureas. These are being used less often now. It is cheap and cheerful. Sulfonylureas work through the sulfonylurea receptor, and as you can see in this cartoon here, normally glucose enters the pancreatic beta cell through the GLUT2, which is a sensing molecule, and glucose enters only according to ambient glucose levels. If glucose levels start to rise, it enters the cell, gets converted to increases the ATP concentration in the cell, which then closes potassium channels and causes influx of calcium into the cell and insulin release from the cell. Sulfonylureas short circuit this process and close the potassium channel even without glucose entering the cell, which means that it can cause degranulation of pancreatic cell. It is particularly useful in people who have monogenic forms of diabetes, HNF1 alpha, HNF4 alpha, where the problem is thought to be not with the production or the number of beta cells, but more with secretion of beta cells. However, it causes increased hypoglycemia, particularly in elderly people, and it's often not recognized as often, and this can lead to falls and injury. Hence, sulfonylurea is probably no longer second-line agent in vulnerable groups of patients. Thiazolidine downs and pioglitazone is the only agent that we have at present. Works by causing maturation of the fat cell, It works on the peroxisome proliferator activator receptor, PPAR gamma receptor. This causes activation of the cellular machinery to make the fat cells more mature, and mature fat cells can store more fat and thereby takes energy away from the blood into fat cells. Hence, predictably, there is weight gain, increased fat content. Osteoporosis may be seen because it might cause increased fat deposition in bone. It does reduce HbA1c, but the main advantage is that there is low risk of hypoglycemia. If we look at these three medications and also at insulin, all of them increase weight. All of them, apart from pioglitazone, increase risk of hypoglycemia. This might be counterintuitive, as we advise patients to avoid weight gain, particularly if you have type 2 diabetes. The newer medications may offer some hope in this regard, and starting with the GLP-1 analog, these are agents that are currently only available as injections. They are hormones that work on the stomach, delaying gastric emptying. It works on the brain, promoting satiety and reducing appetite. It acts on the alpha cell, suppressing postprandial glucagon secretion and reduces hepatic glucose output. But most importantly, it works on the beta cell and enhances glucose-dependent insulin secretion, so low risk of hypoglycemia. This is GLP-1. GLP-1 is an endogenous hormone which is secreted from the distal small intestine in response to food, and thereby we have GLP-1 receptors in the various organs that I described previously: the stomach, the brain, and beta cells. DPP-4 inhibitors work by blocking dipeptidyl peptidase 4, which is an endogenous enzyme that breaks down native GLP-1. As I mentioned, we all have GLP-1, but it's broken down very quickly by DPP-4, and DPP-4 inhibitors block the breakdown, enhancing the endogenous action of endogenous GLP-1. However, the effects are only modest because our own endogenous GLP-1 secretion may be impaired after several years of type 2 diabetes. You can expect a ceiling effect of about 6 to 10 millimoles per liter on average drop in HbA1c. There are various agents in the class, and the only one that probably is worthy of any special mention is linagliptin, which is safe to use in renal impairment as it is excreted by the liver. SGLT2 inhibitors are the new kids on the block. These work by increasing renal excretion of glucose, and you can excrete up to 60 to 80 grams of glucose per day. SGLT2 receptors are the proteins that enhance reabsorption of glucose, which is filtered into the glomerulus. In the proximal convoluted tubule, most of this excreted glucose is reabsorbed, and by blocking SGLT2, this reabsorption stops, and so you have improved glucose levels, and as an additional benefit you get weight loss and blood pressure reduction. However, it's not licensed for weight loss or blood pressure reduction. 90% of reabsorption of glucose takes place in the proximal convoluted tubule. There are 3 agents in this class: empagliflozin, canagliflozin, and dapagliflozin. Empagliflozin was the first drug that actually showed an improvement in all-cause mortality with its use in people with type 2 diabetes, despite only a modest improvement in HbA1c and a modest weight loss. It showed remarkable cardiovascular protection as well as a reduction in all-cause mortality. This may be due to the fact that all surrogate markers point in the right direction, which is weight loss, drop in blood pressure, there is a mild diuretic effect, as well as HbA1c reduction. The CANVAS trial, which is canagliflozin, has also shown a similar effect. This is the glomerulus of a person with advanced diabetic kidney disease with Kimmel-Steele-Wilson nodules, which are eosinophilic nodules in the glomerulus, and this is what you want to avoid. And it has been shown that SGLT2 inhibitors, although there is increased glucose excretion through the glomerulus, it actually protects against renal decline, and there are early studies to show that there is reduction in microalbuminuria as well as improved reduced renal decline. There are multiple trials in progress to prove all-cause mortality improvement. The trial for dapagliflozin is due to be published in 2019, and various other trials are underway. So in summary, when we look at newer medications compared to older ones, the GLP-1s and the SGLT2s show significant improvement in cardiovascular mortality, and this may be due to reduction in the frequency of hypoglycemia, reduction in blood pressure, as well as reduction in weight. In summary, we need to be aware that better treatment in people with type 2 diabetes actually reduces healthcare costs, and we must be looking to reduce the overall expenditure in the patient with type 2 diabetes, and by protecting them from complications, you actually reduce costs. An episode of hypoglycemia costs a significant amount to treat, particularly if there is an ambulance call out or a hip fracture as a result. This is a summary slide once again, and thank you for your attention. If you have any questions with regard to the presentation, please do not hesitate to email me. Thank you.